Hi, everyone, and welcome to a live chat with Nurse Linda. Today's topic is bowel care. Linda Schultz is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. Two quick notes before we start. If you have a question for Nurse Linda during the webinar, please place it in the Q&A box located at the bottom of your screens. Also, today's webinar is being recorded and will be available on the Reeve Foundation YouTube channel. Now I'm going to turn it over to Linda. Hi, Linda.
Hello. Hello, everyone. Thank you for joining us today and welcome to my home. Yet again, we're still here. I'm sure as everyone is still keeping safe during this recovery time of COVID. I'd like to think we've moved into the recovery phase. I'm hopeful anyway. So keep up your stringent care and taking care of yourself. Wear a mask, wash your hands, stay physically distant from people. And of course, if you have the opportunity to get the vaccine, get it. I've been now fully vaccinated, and I've been through my 2-week period of building immunity. So I'm feeling quite confident, but I'm immunocompromised for other reasons, not spinal cord injury. But I think that now is the time to be extra vigilant, because the minute that I felt that freedom of, oh, now I've been fully vaccinated and I've got my immunity and I'm ready to go. And I thought, oh, but COVID is still out there. This is a two-step process. We have to take care of ourselves by using the prevention measures and getting our vaccines. On the other hand, we have to look at the community in general. And when we look at that community out there, we can still see that COVID is very evident, some more in some communities than others, but still it's very evident out there. And of course, it only takes one person to infect 12 other people. So you just want to be very cautious and very careful. We're at a very critical juncture. I think that people are feeling quite excited about being back and going out and doing things and being with other people. And there are some guidelines that if you are fully vaccinated, you can be with other people in small groups. So just be cautious. Know what's going on. Know who you're dealing with. If you are going with family, check to see if they've had vaccines. If they haven't had vaccines, you want to be sure and keep your distance, even though you've had yours. Now, the vaccines have a percentage that they are a percentage of immunity. A good vaccine has about 70% immunity rating. The Pfizer and the Moderna ones are touting 90%, which is great. The Johnson & Johnson is about the 70 mark, so that's standard. But what that means is that you still have that slight little chance that you could still catch it. If you have the vaccination, you can still carry it, not get the COVID, but you can still carry it and give it to other people. So you see, it's kind of, if you go with somebody, they've had the vaccines and you think, oh, okay, I've had mine, they've had theirs, we're all safe. You could still, and they could still carry it, you could still give it to each other. Now, hopefully with the vaccine, you wouldn't get as sick as somebody who was not vaccinated, or your chances of dying from it are a lot less. So that's a lot of benefits with the vaccine, but just know that, it's nothing is 100% guaranteed out there. It's healthcare. Strange things happen in healthcare all the time. But today's topic is bowels. And so we'll get started on that one. Now there's something that's coming up next month in April, and be sure and look for it. The Reeve Foundation is having their annual summit. If you got to go to the first one last year, it was just terrific. This year will be virtual, so it'll be all online. I am also doing a presentation about bowels, but it's not really to talk about me, to talk so much about it, but it's working with people that are attending that particular session with me. And so I'll be looking for, I see popped up if you register for that. I'll be looking for audience participation. The focus is on audience participation in all of the summit this year. So I'll be looking for your comments. And what I'm really looking for is something that maybe you do that you don't even think is special, but something that works in your bowel program, because we all know when the bowel program goes great, life is great. But then for some reason, whatever, something happens in the bowel program and it doesn't go so well. For some people, the bowel program is really a challenge. So if there's anything at all that you're doing in food, drink, movement, medications, anything that you're doing, or just some technique that you're finding that's working out for you, we'll be going through the different sections and asking about that. So be prepared to come to that session and please contribute. And if you just want to hear more about what other people are doing, this will be, kind of off the grid kind of things. Just tell us what you're doing and it will maybe be the answer for somebody else. Wouldn't that make you feel great if you had the one piece of information that somebody else is like, aha, that solves my problems? So there are two big things that happen in the world of neurogenic bowel. Neurogenic bowel is what results after spinal cord injury. It's a problem with nerve communication. The bowel and the brain aren't talking back and forth to each other as well as they could be. And so that's why there's a special term, neurogenic bowel. Now, a lot of people will look at the stool and they'll say, oh, this stool is really hard and dry. I'm constipated. Well, you can be constipated with a neurogenic bowel, but treating constipation will not treat neurogenic bowel. So you have to think, I have neurogenic bowel. In that, you can have diarrhea, you can have constipation, you could have any kind of bowel issue that anybody else could have. But the focus of the problem is neurogenic bowel. So keep that in mind. And that's what we have to treat. Now, the Paralyzed Veterans of America, they have a series of booklets that they put out, their guideline booklets for spinal cord injury. They have all kinds of topics. You can just go online to Paralyzed Veterans of America, type in the search bar guidelines, and the booklets become available to you. Now, you do have to give your name and information, and then they send you a copy of the guideline booklet, all for free. So it's wonderful. I have them all. I live by them all. They're really great. They have a lot of helpful information. They released a new guideline for neurogenic bowel after spinal cord injury. So this is an important piece of information because there are a couple of changes. And so I really want to highlight those. One of the things is using the fiber laxatives. Now you notice that in my past writings, I have recommended fiber laxatives. Those are things like Metamucil, Citrasil. They're called fiber laxative because they help your bowels function, but they're not a laxative like something that you take that's going to cause a bowel movement right away. They increase the bulk, they increase the fiber in the stool. And if you have a neurogenic bowel, that bowel needs to grab onto something for it to move it along. The intestines have this peristalsis, it's called. It's like, put my hands in front of my face here, but it's like it contracts and pushes the stool along in the bowel. So if it has a little bulk, it's easier to push something along. So we have always recommended these fiber laxatives. So this is an important factor, is that you'll notice when I talk about it, I always say you have to take the amount of fluid recommended. And when I go to different hospitals, healthcare facilities, long-term care facilities, I see people getting their fiber laxative, and sometimes they put it in like a 30 cc medicine cup, and they'll put like a whole teaspoon of that powder in a 30 cc. So, people are only getting like at the most, rarely even 20 cc's of water, like a swallow. And so you have to take the fiber laxative with 8 ounces of water. If you have a neurogenic bowel and you also have a neurogenic bladder, you might be on a bladder program that doesn't allow you to take one full glass of water at a time. That would really upset and, overwhelm your bladder program and lead to kidney problems. So, we don't want to do that. So sometimes people will divide the dosing of the fiber laxative up into several different one dose into several different water episodes that they're taking, so that they get the full amount of water, but just not all at one time. And that's an okay thing to do. But with the new PVA guidelines, they said, so many people are not able to consume the amount of water that's needed with the fiber laxative. We're not recommending it anymore. So that is something to think about. Is it going to hurt you if you're still on the fiber laxative and it's working? No, keep up with it if it's working for you, but know that you have to take the amount of water. So the guidelines are not recommending those fiber laxatives. And what they have found through research, all these guidelines are based on review of research and taking all the research findings on different subjects and putting it together and looking at what is the best practice. So they rate all the evidence, all the research. Was the research done really well? Was the format of the research structured well? And they grade all the levels of research, and then they put all this evidence together. So they're no longer recommending fiber laxative. And in fact, what they're saying is that most people don't need that many additive preparations, that even though the bowel works slower, that people don't need to take all of these different preparations that they're taking. Now, let's look at this. That does not mean stop taking everything. Keep doing what you're doing. Always discuss with your healthcare professional about making any kind of changes to anything that you're doing, because you can upset that one thing. It's like a Jello mold. If you jiggle it over here, it's going to jiggle over there. So one thing affects another thing, even in bowel preparations. But what we do find in healthcare, and we find this just very, very often, is that sometimes people will have one day of diarrhea. And so they start taking a treatment for chronic diarrhea, and then their stool becomes too hard. And so they start taking stool softeners. Oh, and then the diarrhea comes back because now they've got too much stool softener. So they increase or start taking more things to contradict the diarrhea. And sometimes we'll look at people's medicine chart and they have like 20 bowel preparations that they're taking to loosen the stool, soften the stool. It just goes on and on. And so we just like, okay, let's just get off of those and let's see what we have before we start doing that. Now, many people with neurogenic bowel need some kind of preparations, but sometimes we find that people just have something else ordered, have something else ordered, have something, and they're on so much that the bowel just becomes paralyzed. On the fiber laxative, if you cannot take that full dose of water with a full dose of fiber laxative, what happens is that that laxative, the fiber in the Metamucil or the Citracil or the other products, it needs that water to expand the product in your bowel. So if you don't take enough water with it, it becomes like cement in there. And that's what really becomes more of a showstopper rather than a bowel mover. So that's some of the reasons for that. Now, the other thing that's going on that's really big is for pediatrics. There's a new neurogenic bowel guideline that's put out by the Spina Bifida Association. Now, your child may not have Spina Bifida. If they do, perfect. You can go to the Spina Bifida Association website and you can click on their new bowel guideline. But if your child doesn't have Spina Bifida, it's still neurogenic bowel. So you can use that as kind of a guide. You need to think, no matter what you're doing, you need to think about, is this right for me? It doesn't matter if it's neurogenic bowel for spinal cord injury, and that's exactly, what I have. You always need to think, is this the right thing for me? What are the risks? What are the benefits of doing these things? But what's nice about the Spina Bifida guideline is it goes by age group. So there's questions in there that you can think about, for 0 to, I forget how the ages go, 0 to 1 or 3, and then the next age group. So there's blocks of ages in there. So even if your child doesn't have spina bifida, there's going to be some helpful questions for you to ask your healthcare provider. A lot of times, particularly with spina bifida or any children with a neurogenic bowel, infants sometimes have a stool, but they don't completely evacuate their bowels with neurogenic bowels. But people will say, well, they're evacuating stool, so they don't need a bowel program. We'll start that when they get older. No, if you have a neurogenic bowel, you need a bowel program to eliminate that waste, because the waste that's left in the stool is going to back up, especially in infants. I hear this a lot with infants. Oh, they don't need a bowel program because, they have spontaneous emptying and babies wear diapers. So, there's no problem there, right? Well, yeah, because, that bowel is not functioning properly, stool's being left in there, and then those children end up with problems with their bowels for lifetime. So it's a good idea. The Reeve Foundation has plenty of information about Neurogenic Bowel Program too. I don't want to leave them out. It's all for free. So it's a good opportunity to get all this information. So let's go ahead and start looking at some of the questions. And I see there's some in the chat, and I have some on my computer that have been sent in earlier as well. Now, if we don't get to your question today, I always like to point out that I am on the community on Wednesday evenings, and you can put your question in the chat box in the community, in the Reeve Foundation on their community, or there's a way that you can email me. There's a little email icon, and you can email me directly if you don't, if you think, oh, this is too personal, or I don't want my name on this or whatever. So there's different ways that you can reach me if you want, I just have this burning question. So here's the first question is that with the bowel program, a physical therapist taught them to use a balance board as a part of aquatic exercises. Core exercise is part of the reason for using. Okay, so that's a good suggestion. If you can help improve your core strength, that abdominal muscles are what are really being used to help with bowel function. That's for anybody. Your abdominal muscles are key to that. When you move your body, if you move your legs, if you're walking, those muscles, the muscles are all connected together. So those muscles help the abdominal muscles. If you can't walk or you have poor sensation and difficulty moving your body, you can still take advantage of muscle movement by doing range of motion exercises, any way that you can move your legs. If you have any exercise programs, any equipment that ranges. If you can't range your legs, have somebody else do it, because movement is so key to bowels. So even if you can tighten your core, even when you're pushing your wheelchair, or if you're doing those wheelchair push-ups where you put your hands on the armrests and push yourself up, that's helping to stimulate the core of your body. So very important. You'll also notice that the bowel management link to the bowel management booklet is there in the chat box. So that's something important for you to click onto. If you don't have that, you'll want to be sure and get that. So I have some questions, and I'm just going to run down the list. This is kind of a different topic, but one of the first question on here is about the latest in stem cell, that there's some stem cell information coming out of Medellin, Colombia, and Phoenix. And so they say that I think that it's recommended maybe for them. Stem cells are really very new. They're not new. They've been around for they've been around for a long. Particularly in spinal cord injury, there was a boom in stem cell research about 20 years ago. And it kind of slowed down because there was a lot of success in developing nerve stem cells. There was a lot of success in implanting nerve stem cells into people. But the stem cells need to go in after you have a spinal cord injury. There's a little hole that develops around the area of injury in the center of the spine. The stem cells need to go in there. And they were having difficulty getting the stem cells to grow through the scar around this little hole. It makes your spine almost look like a donut. So there's like the center of the hole of the donut, right where the injury is. They were having a lot of trouble to get those stem cells to grow out of that center hole. But they've worked on that, and they have scaffolding, and they have all kinds of things so that those stem cells can grow and can grow out, but it's still kind of new. So I do know about the clinic in Medellin, and a lot of these clinics in Central America, South America, and some islands are connected with very reputable institutes in the United States. However, it's kind of new for all of this. So whenever you have somebody who says, oh, I have, and there's been a lot of these, we have stem cell cures, give us money. It doesn't go through insurance because they're not quite yet, what would be the word that I'm looking for? It's not something that has been fully demonstrated to be effective. So if you're asked to pay thousands of dollars on your own, and it's kind of one clinic kind of thing, you probably want to avoid that. You want to be sure and get involved in research studies that are managed by oversight organizations, not independent studies, because those tend to have a lot of maybe misinformation about them. So you need to be very, very cautious. You want to be really involved in studies that are regulated by the FDA in this country, because that's your safety mechanism. If somebody has a stem cell treatment, it doesn't go through insurance. Insurance is not paying for it because it has not been validated. When something is validated that is proven effective, that's when insurance begins covering. And insurance, I mean public and private payers. So be very careful about that. You can go to clinicaltrials.gov, and that's where you will see all the approved, safety watched trials are listed through there. Doesn't mean that you have to participate in them. It means you can read about them, get the information, and then decide. It really helps you get more information. Question about non-drug relief for tone and spasticity. There are people that are using biofeedback to reduce their tone and spasticity for relaxation. Movement certainly helps tone, spasticity. Tone is the new word for spasticity. So gentle movement, range of motion helps decrease tone. It fatigues the muscle. It helps to reduce some spasticity in that tone. It also helps in pain. A lot of people think, oh, but I hurt. I don't want to move. You know, my wrist hurts. I don't want to move it. But if you just very gently range it out, you know, people who have arthritis, if they use gentle movement, that doesn't disrupt their arthritis pain. It's when you do those real hard pushing exercises. Here's a question about bowels. I take many products for my bowel routine, and they're going to go to surgery soon, which will require a 2-week stay. I know I can't bring my supplements in the hospital, and is really nervous about maintaining his routine. Actually, hospitals will provide supplements. So check with them. I don't know if you've experienced before where they say, no, they won't give this particular thing or that particular thing. Sometimes your physician can write an order that you can take medications from your home supply if it's a certain kind of supplement. So talk to your physician, talk to your surgeon. That will be the one who will be in charge of you during your recovery time in the hospital, and explain that this is the treatment that you need, that this maintains your bowels. Now, it could be that when you go into the hospital, it could be that they might decide to control your bowels through enemas, or, you know, you want to keep up with your bowel program. You don't really want to switch to that, and explain to them why you're about to take the bowel booklet from the Reeve Foundation that explains the management of neurogenic bowel. So that would be a helpful piece of information. You know, a lot of people in the hospital don't have that much experience in neurogenic bowel, so they don't really understand it. I know that there's, so take your information with you, the bowel booklet that explains what you're doing and why you're doing it, so that you can keep up with your routine. Sometimes they'll let a family member come in and manage the bowel routine. If you have some way that you're doing it, you might not be able to sit up if you have to lay in bed after surgery, or there might be some precautions. So that, you know, that is an issue, but, you know, you have to, you're going for the surgery. You want to do what's needed to recover from the surgery as well. I know there's also a question in the list here about somebody who's going for a colonoscopy. And so they're worried about that because, you know, you have the big flush before the colonoscopy. You have to clear out your whole entire bowel so they can see what's going on in there. So now this is the thing, is that many insurance companies now, if you have a spinal cord injury, are allowing you to go into the hospital the night before so that the personnel in the hospital can do the bowel prep before the colonoscopy. So call that number on the back of your card. If you have an insurance nurse case manager, talk to your insurance case manager, because many insurance and payers are allowing this. It's really difficult to do a bowel prep when you're at home. You can't sit on the toilet that long. You don't know when the results are going to come. Sometimes people elect to do the bowel prep in the bed and, you know, just recline for that whole period of time, because you don't want to be sitting up that long because it's too much pressure in the rectal area, because that's not supported, because the toilet seat or the commode seat has that hole in so that, you know, things can pass through there. But those are a couple of different ideas for that. Best tips for airline travel for a person with spinal cord injury. Well, of course, avoiding airline travel is probably the best thing, but because it really is an area where you're putting yourself at risk. Now, there's a lot of news about airlines and how they have good airflow. And if you have that, you know, that little knob up here that you can get the airflow, and if it blows down, you're blowing this air that's, they say it's clean air that's blowing down over you. So that makes the airflow the direction going this way instead of air currents traveling around your body. So you want to keep that little spigot open. Be sure and wear your mask. Be sure and try to have a seat. Some airlines are still putting people far away from each other. Some are not. I want to say Southwest or Delta is still not filling the middle seat, but other places are. So you could have somebody, you know, shoulder to shoulder next to you. Now, I don't know that they're asking for your card that people have been vaccinated. You can still fly if you have not been vaccinated. So some people will be and some people won't be. So it's air travel, because you're in such an enclosed space and so close to other people, it's kind of against some of the guidelines. So it depends on, you know, how necessary is the air travel. If, you know, if you're required to do it for some particular reason, or if you can put it off, that's probably a good idea too. So can quad sweat. Usually people do not sweat below the level of their injury, although everybody's injury is different, and some people do. Some people have hypernephrosis, which means very high levels of sweating below the level of their injury, because, you know, everybody is a little bit unique. So can you? Yes, but it is very rare. Most people who have a spinal cord injury do not sweat. So they're having heat-related rashes, especially in the groin. And if I'm not sweating, where's that moisture coming from? Well, it could be coming from just the fact that when you're sitting and your legs are together, and you know, maybe your abdomen is a little bit hanging over your thighs a little bit. So sometimes just the heat of your body can produce that. If you've had any kind of lotions on there, you want to kind of avoid that in that particular area because those are moist and that creates moisture. Sometimes your bowel, your rectum releases moisture. So, you know, everybody passes gas. Even if you have a spinal cord injury, you're still going to be passing gas. And that moisture gets in there and then it kind of just creeps all around in those folds of the body. So that is something to think about. Moisture comes from a variety of places. Maybe you didn't get dried thoroughly. You know, you can dry off with a towel and you appear to be dry, but there's still a little, maybe bit of moisture there, especially if you dried the genital area with a damp towel. Maybe it didn't get it as dry as it needed to be. So there's a lot of ways that moisture collects in that particular area. That's why people need to kind of lay in bed at night in the frog position and kind of let things air out in there. If there's some kind of rash, maybe there's been some kind of ointment that's been put on there, and that also gets some moisture in there. Okay, so here's a person that broke their femur 5 years ago and their ortho surgeon did not want to operate since I will never walk. Frustrating. Check now. That was a theory a while ago, but we know that the body structure is based off the skeleton. That's what holds us, our bodies all together. So when there's a disruption in the skeletal system, then maybe your seating isn't as good as it should be, or you know, you can end up with a different kind of contractures or different problems because of the disruption in the skeletal system. You know, we all need parts of our body, whether we walk or not. So, you know, that's kind of yesterday's thinking. So ask if you can have that repaired now. There might be too much of a callus around the bone. It might be too much of a big surgery 5 years later, but the leg is double in size and hangs off the chair. So you can, he wants to know what to keep this chair, the leg on the chair and keep from swelling. So there are adaptations to your wheelchair that you can get that can support the area. So talk to your healthcare professional and your physical therapist, because that certainly would help. Having a positioning device would certainly help. You might need to have an elevated leg rest to keep the swelling down. You know, when we're not moving our legs, we tend to swell. People who take long airplane rides, they'll come out with a little bit of edema in their ankles because they haven't been moving them enough. So if you're able to move the leg with a fracture, you might not be able to move it that much, but if you can do some range of motion, check first, check, always check. And then maybe also a stocking on that leg, an elastic stocking that would help to be able to reduce some of that swelling. And when you're in bed at night, you need to put your leg up higher than your heart. Again, you'll need to check because of this fracture. I don't know what's going on with that fracture, and I don't want it to be displaced even more or to create some kind of problem for you. So I'm just making suggestions that you can check with your healthcare professional and ask about. If you can position your leg at night to be higher than your heart, that will eventually get that edema to go down. There are also machines that they have where you just put like a wraparound device around your leg, and then it massages the legs and helps. People get them after surgery, sequential compression devices, and that can help reduce some of that swelling. And so you might need to use that even just for a temporary time until you can get that swelling under control. Okay. Here's a person who has been paralyzed for 2 years, quadriplegic. Is there any way that he could walk again? Well, I'd like to think everybody will walk again if that's what they choose to do. Now, we don't quite have all that information pulled together yet. People are still working on it, but there has been so much progress. Now, my personal feeling And speaking as a person who had a family member with spinal cord injury, a close family member with a spinal cord injury, so I was the primary caretaker. Um, to me, 1 day, 1 minute, 1 second being paralyzed is way too long. Because I've lived that world, and it propels me on. But anyway, yes, I think that there's treatments that are coming. I know it's so hard to wait. And I wish for my family member, I wish that they could have taken advantage of some of these treatments, but it's too late for them. They passed on. But so I think, yes, swimming therapy is a wonderful therapy. If you can do aquatic therapy, not everyone has access to it, but it is wonderful because the buoyancy of the water removes a lot of the resistance of the body move from gravity. So if you can get aquatic therapy, Christopher Reeve had aquatic therapy, and it was just wonderful because he could, with all of his other therapies, he developed some movement. He had movement in every joint of his body, but gravity kept him away from it, just wasn't strong enough at that particular point in time. However, in the water with the buoyancy, he could, with somebody holding him up, because balance is a separate issue. So with somebody holding him up on each side of his body, he could walk from one side of the pool to the other, lifting up his foot, moving his leg forward, moving his body forward. He could do that in the water. Once you learn to do something in the water, and your body then is learning the new nerve routing system for that activity, you can strengthen that and learn to do it outside of the water. So it's a wonderful, wonderful activity. I recommend it for everyone, but there again, it's so difficult to find therapy, aquatic therapy, and to get the resources to pay for it. Everybody has in their payer usually 2 weeks of mobility training. You can use aquatic therapy as mobility training for 2 weeks of therapy. It doesn't have to be Monday through Friday and then Monday through Friday. It could be like one time a week spread out. So check to see if there's an aquatic therapy, and you might be able to gain that use that benefit to your better ability. So what's the best way as a caregiver to get back to prior to injury? How can I best help people? And I personally think it's through movement. The body is made to move. It wants to move. It craves movement. After spinal cord injury, that signals to your body, those electrical signals are basically silent, but you can provide that kind of stimulation through moving a person's body. So if you can move their body, that is one of the best things to do. You always want to check before you start any kind of movement program, because somebody could have a hidden blood clot, there could be a contracture, there's all kinds of things. Maybe they have cardiac issue. There's just the list is long. So always check with a healthcare provider, but moving a person's body where they can't move it provides that electrical input. So you have the signals going from the body up to the brain. The person should be thinking, if you're moving their toe or moving their ankle or moving their leg, thinking about moving it, look at it moving, so that message is being created in the brain, and hopefully together it'll come pulled together at some point in time. So what are the best drugs, foods to have a daily form bowel movement? That is a good question. So I know what most people take, and most people take daily Colase. They might oral pill for stool softener. Most people take maybe some Spina as the day of their bowel program, if not more frequently. People were with higher level injuries taking bulk fiber laxative, the Metamucils, that sort of thing. All of that is good. The more fluid that you can drink, water especially, that is really helpful to keep the stool moist. When you take in food and you chew it up, it goes into your stomach. it leaves your stomach in a substance we call chyme, and the gallbladder secretes some digestive things into it. The liver does its thing. Anyway, all those organs are working in there. It gets to the bowel, and the bowel starts extracting the nutrients out of this chyme in the small intestines. But as it does that, it's extracting fluid. That's why at the top of your bowel, things go in more as a thick liquid, but when they come out, it comes out in a form stool because the water has been removed. So the more water you can take in, the more loose your stool is going to be, and the easier it is for that chyme to pass through. Now, dietary, you want to add that fiber, add that bulk. So again, that the bowel has something to kind of grab onto. If you try to grab onto water, what's going to happen? It's just going to randomly flow around out of your hand. But if you grab onto something that's moist, it's kind of a solid that's easier to hold on to. The same thing happens in your bowel. There is a scale out, it's called the Bristol Scale. It's developed at a hospital in Bristol, England, and it's pretty readily available, and it shows different types of stool. So it's got two types where you need to add more water. It's got two types on this, it's a scale. It's got two types. There's a picture of it. There's description of the stool. It sounds kind of macabre, but it's very helpful. And then there's two types that are considered normal, the form stool, and then maybe one that's a little bit looser. But when you get to the stool that's too dry and the pictures of that, you think, oh, I need to add more fluid. When you get to the part where it's too loose, you think, oh, okay, I need to do something to help solidify my stools to get them more formed. And so you can add more fiber. You can add any of these bulk formers. So the Bristol scale is something that's very handy because you can monitor your stools. There's also now a Bristol Scale app. It is free. There are all kinds of stool tracker apps. These became very popular with people who have colitis, and they need to really follow their stool. So it's helpful to have one of these apps, because if I would say to you, what's your stool like? Well, let's see. My last brow program, it looked like this. Well, what did it look like 2 weeks ago last Wednesday? Well, I don't know. Well, who does? But if you have one of these apps, it kind of tracks it along, because one of the things that you don't want to do with your bowel care is somebody has a loose stool one day and boom, they're on the medications, kind of like what I was saying earlier. And so then the next day, they've taken their antidiarrheal medicine, and the next day is a little bit hard to pass. And so boom, they're taking the softener. So if you use one of these apps and track along and monitor how your stool is doing, if you have multiple healthcare givers that are helping you with this, then everybody can see exactly what's going on. And it will help you notice over time changes in your stool. So if you have one day that your stool's a little bit hard, you can drink more water, you can add more fiber, and maybe tomorrow the stool's not quite that way. Stool is kind of finicky. It depends on your fluid intake, it depends on your diet, it depends on your activity. It also depends on your mindset. So if you're anxious about something, guess what? It affects your bowels. If you've ever heard about, somebody, oh, I get nervous, I had diarrhea. Anxiety tends to speed up the bowel. So changes in our mindset and how we feel that day, if we're worried about something or whatever. There was a delightful, and only a person who is into spinal cord injury or have one could find this delightful. But I wish I kept this, because there was a gentleman who did a blog. It's been quite some time ago, and I wish I had it. I wish I had kept it, because I would love to give him credit for this. But he just wrote this fabulous story about his bowels, and he was talking about, he had gotten engaged and he was going to meet the fiance's parents, and he was all excited about this. And it was a happiness, so it was good, but there was a lot of anxiety. I'm going to meet my girl's parents. What are they going to say about me? I mean, everybody has these same feelings, right? Well, anyway, so as it turns out, they're in the car and they're on the way. And what happens? He gets incontinent of his bowels in the car ride to these people's. Well, he had some sweats and he got himself changed. And anyway, he just told it. It was so humorous. Not making fun of anything, but it was just like, oh yeah, I get it. This is, bowels move at the least opportune time. I think we all know about that. So anyway, there's a comment here is a friend. I'm trying to look to see. I think her name is also Linda. Thank you for taking care of Chris. What a wonderful experience that was. I've talked a little bit about that, and wow, that's really nice. So here's another question about leg jerking, feeling burning and cold at the same time. So as much as we hate to see anybody being discomforted, when you have leg jerking, which is probably spasms, feeling of burning and cold at the same time, those are miscommunications by the nerves. Good news here is there's a nerve communication going on. It's abnormal. It's not being interpreted correctly, but something is getting through. So it's kind of a wonderful thing. Now, spasticity, on the other hand, there is a reflex arc within the muscle itself. And sometimes that loop just gets, because again, those muscles want to stretch and those muscles want to move. And if they're not, the stretch reflex says, how come you're not moving? So I'm going to make it move. So that creates spasticity. It can be from a nerve miscommunication from the brain. It can be from within the nerve itself. So if you're having those kinds of sensations, some gentle movement may help resolve that. Again, it has to be gentle, because the harder you move those things, the faster you move it, the harder you stimulate that, the more you're going to increase those noxious, those bad stimuli. So you want to be very gentle with that. There's medications you can also take if you are feeling like that's such a problem that it cannot be controlled. So something to look into. What could I do to prevent chronic constipation for paraplegia? Now, this brings up a very interesting topic, because the motor neurons are the ones, neurons is another word for nerves. So motor nerves are the ones that are regulating the bowel. And the bowels run through the autonomic nervous system. Now, we all know what problems the autonomic nervous system, that's the nervous system that happens automatically. So we all know that there's problems with that after spinal cord injury. So motor nerves arise in the brain and they arise in the spine. So the ones that arise in the brain are, directly controlled by the brain. Those are called the upper motor neurons, because they're up higher. And then when those motor neurons are affected, that's when you have more tone or spasticity. So everything is more hyper. Lower motor neurons are down in the spine. The upper motor neurons will go down in the spine and connect to the lower motor neurons. When those are affected, that's when things become flaccid, way too relaxed, no tone at all, or very little tone. So issues with people who have cervical or thoracic injuries are generally, not always, generally upper motor neurons. So that's why people who have cervical or thoracic injuries tend to have more tone or spasticity. The tone or spasticity in the bowel, if you see it on the outside of the body, it's on the inside of the body. So the bowel might be spasming, so that's harder to get the stool through it. The internal sphincter of the bowel will clamp down and not let the stool out. That's why you have to do the dig stim. You do the suppository to get the bowel activated, to get it moving, and then you do the dig stim. Now, people in the lumbar and sacral areas of the spinal cord generally have this lower motor neuron injury, but not always, but generally speaking. That is more of a flaccid bowel. So the stool travels through the bowel and then it is manually removed. You can try a suppository, probably won't work. Sometimes some of the mini enemas, not the full enemas, you want to avoid those because they go too high up in the bowel and flush things out and kind of destroy the workings of the bowel, the natural workings. But the mini enemas just act really in the rectal vault. Sometimes those will work, and they've been demonstrated to work in the lower bowel. But mostly what you can do, the internal sphincter is flaccid, so there's no tone there. So mostly people will just do manual removal of their bowel. So to prevent chronic constipation, again, is drinking the fluids. Now, if you're on a bladder program, you need to control your fluids, so you have to watch how much you drink. And so that kind of confounds things a bit, but drink the fluids that you are allowed to drink. The other thing is to look at your fiber and to evacuate the bowel. Now, some people will do that digitally every other day. A lot of people do it every day. Some people do it at every toileting because they're so worried about being incontinent because of that internal sphincter being flaccid. There's nothing to hold the stool in there, so it tends to just come out at the most inopportune time. So doing those things, moving your body, moving your body, moving your body. So if you have a lower level injury, if you have braces, sometimes people have reciprocal gait orthotics where they can, it helps their legs swing while they use maybe crutches or a walker. Sometimes people do that, and it's very functional for them to walk around doing that. So if you can use those, that helps activate those muscles in the abdomen. A lot of times people give those up because they're heavy and it's a lot of upper body energy to use those, and they wear out. They say, oh, I'm just not going to use it. I'd rather use my chair because I'm too exhausted all the time. I'm physically exhausted. So if you have those, use them as an exercise. Use them one time a day as an exercise period to help move your body around. So those kind of things are all help if you have an upper or lower motor neuron injury. All of those things help everybody. People who don't have spinal cord injury, it helps them too if they have constipation. Here's a question: is digital stimulation dangerous or is it helpful? Well, digital stimulation is not dangerous. I know there's a question about that on both question boards here. It's not dangerous, but you want to be very cautious with it. You want to be careful. Again, I have yet to meet anybody who's had a spinal cord injury, and I've yet to meet when I go in and say, well, now let me explain to you the bowel program. This is what you need to do. I have yet to hear anybody say, oh, goody, I've been waiting for you to do this my whole life. You know, it's foreign to people. This is not something that is talked about. It's not something that people know about. And it's like, wait a minute, I have to do what in my rear end? You know, that is usually the, oh, kind of moment. But after you get doing it, becomes, you know, it becomes your new normal. So is digital stimulation dangerous? If you lubricate, you should be fine with digital stimulation. It's not going to overstretch anything because you're not going to be, you know, you're just doing a gentle finger swirl. The external sphincter, the one that you see, is not your target. It's the internal sphincter, the one that you can't see. There's two sphincters. The external one you see, that's your rectum. And then the internal sphincter is about a finger length distance up inside your bowel. That is the one that needs to be relaxed. So that is the one that in the upper motor, that's the target item. If you properly lubricate, and some people are very cautious with their lubricant, or they just put it on the tip of their finger and they think it's going to spread magically around on their glove, and it is not. If you become too aggressive, you know, your internal tissue is all very delicate and gentle. So you don't want to be you don't want to be aggressive with your digital stimulation. You want to be gentle. For the upper motor neuron bowel, you want to relax that internal sphincter. If you go in and start poking at it and really aggressively swirling around in there, what's going to happen to that spastic sphincter? It's going to tighten even more. So the more harder you do your digital stimulation, the more difficult it's going to be to evacuate your bowel. It's not going to relax, it's going to tighten things. On the other hand, if you have the lower level kind of bowel, that flaccid bowel, you're just going to go in and gently remove the stool out. And once you open up that bowel area, the stool really come out. Sometimes you kind of have to get your finger hooked around the stool to help it kind of flow out. But you just want to be very careful with it. Again, you want to be very gentle. And so you don't have to, really do anything more than a finger's width in the stimulation. So it's digital stimulation is very helpful, but you want to be cautious with it. Sometimes people are so aggressive, or like I say, they put the lubricant on the tip of the finger, but not on the end of the finger. And then it's dry towards the rectal end. So you put the lubricant on the tip, and then the end of the finger here by your hand is dry. And then that's up against that moist tissue inside the rectum. And that's when the hemorrhoids start to flare out. So you want to be sure and lubricate all of this to really get, to be sure that you've got adequate moisture in there. Is there a better type of suppository? I use the Dulcolax. Some people use the magic bullets, other enemies. So which is the best? That's a very good question. I love that question. So the Dulcolax suppository has a vegetable coating on it. The magic bullet does not. It's the exact same formulation of stimulant. They're the exact same thing. The Dulcolax has a coating that you have to allow to melt. The magic bullet doesn't. So some people say, oh, I love the magic bullet because it's so much faster. Other people say, oh no, I like the Dulcolax because it gives me a little bit more time to get to the commode. The suppositories, no matter, and the mini enemas do not work unless they activate up against the bowel wall. So sometimes people will put a suppository in and there's already stool there in the rectal vault. That's the place right before it comes out. And so they put the suppository in, or they put the mini enema in, and it goes right into the center of that stool. It's never going to activate, and it is never going to work. Now that's pretty dramatic. I mean, it could work, but what makes these things work is when they hit the bowel wall. So you might need to remove some stool before you put it in, or if you can slide it around to get those suppositories or that enema onto the bowel wall, that is when they work. And I think that's why a lot of people's bowel programs don't work so well, is they just want to slip the suppository or the mini enema up there, and it's in the middle of stool and nothing's going to happen. Now the mini enemas, there's Theravac and Enemies. They're both great products. They're very small. Again, you don't want to do the full enema. These only work in the rectal vault, but again, and they seem to work very quickly. The products will say they work in about 15 minutes. The other products, the suppository should also work in that amount of time. Now for children and elderly people, you might use a glycerin suppository. Some people will find that they have too much mucus production after using the suppository. And so what you can do is cut the suppository in half longwise, because you want that full suppository length up against the bowel wall for maximum stimulation. But sometimes the Dulcolax or the magic bullet might be still stimulating after your bowel has emptied, and then you get that big mucus production that comes out at the end of the bowel program, or even worse, 15 or 20 minutes after your bowel program's over and you've cleaned up and you've gotten dressed. So sometimes you can cut those in half. Sometimes people will use a glycerin suppository because it is an irritant, but it's not as strong as the Dulux or Magic Bullet. Sometimes people will use who have kind of, maybe they don't have a complete injury, so they do have some sensation in their rectal area. Sometimes they'll use an analgesic, which can also be used as a lubricant. That will help reduce some of that irritant if you're having pain when you have your bowel program. If you have a complete injury, you probably won't. If you have autonomic dysreflexia, when you're doing your bowel program, you can use one of these analgesics. There's hemorrhoid creams like Nuprocanol that have an analgesic that you can buy over the counter that will reduce some of those responses and those nerve fibers that are creating your AD or creating pain or spasms during your bowel program. Or there's actually prescription formulations that you can also use. So just some little tips about those. So those, there's all different kinds of things that, people want to do their bowel program, they want to get in and they want to get out. But you really need to take that time with that digital stimulation. Now, there was another question about passing gas, and it's difficult sometimes because the bowel's not moving as functionally as it could be. So sometimes people have a lot of gas buildup. So sometimes people take something like Gas X, but gas is important. You don't really want to reduce your gas. That's what helps propel the stool along in the bowel also. So to help expel some of that gas is to do some range of motion exercises to the legs. You can do any kind of exercises. If you are doing pressure releases in your chair, if you can do the kind where you lean from one side and then hang over for a while, that's moving your abdomen as well as it's moving your upper body. So if you're doing your pressure releases that way, if you can do your pressure releases so you're leaning forward, that also is crunching your abdomen just with the pressure of your body weight. Now be careful when you're doing those side to side and forward. If you have balance issues, which a lot of people have trouble knowing where their body is in space after spinal cord injury, so they'll fall out of their wheelchair. So be sure and hold on until you get used to doing it. Have somebody there with you that's doing it. If you have a higher level injury, use the tilt on your wheelchair to tilt back and forth. You're moving your body as you're doing that. It's very helpful. If you're in bed, rolling from side to side, that's moving your body. So anything you can do to move your body. And then also, if you have a lot of gas, look at the kind of food you're eating. A lot of foods create a lot of gas, and we tell people to eat foods high in fiber, like beans that create a lot of gas, because that is helping to propel the stool along. But maybe you're eating too much of that. So maybe you can cut back on that a little bit. Don't cut back too much so that you don't end up losing your gas production that is affecting your bowel program. What about the CEO, the 2 laxative suppository? It says less cramping. For some people, they have cramping with the Dulux. For other people, they don't. Bowels are a trial and error. Nobody's bowel is exactly the same. Everybody's going to be a little bit different in what they're doing. And so what works for one person, you might have a best friend, same level of injury, same time since injury, same, but your bowels are completely different. And all of ours are. So all of those functions are different. So with that, we are at the top of the hour. I'm sorry I did not get to a lot of the questions. I think what we'll do is we'll continue this discussion next month, because we will have the information gathered from the summit as well. And so we'll have a lot of things that I want to report on that. So if I didn't get to your question this month, you can always write it in the community if you need an answer quicker, faster, or we'll use this list of questions for next month as well. And we'll have more information from what your colleagues are doing with their bowel program, which I think is going to be just great. So with that, I say, be careful, Be wise in your decisions in going out in the world. Remember to be cautious. This is a time of great optimism. And, we're also happy to be on the downhill slide of this. Let's make sure that we don't get in that little trend that seems to be creeping up a little bit. So just be cautious with yourself. We've made it this far. We're going to make it the whole way, right? All right. So have a great month, and I'll see you next month.